Hi, everyone, and welcome to this episode of Sleep Like a Boss podcast. My name is Nyhagen, and I'm a sleep therapist. I work with cognitive behavioral therapy for insomnia, and often I meet clients who also have sleep apnea. What worries me is that there is not much knowledge and awareness about this, and people might have sleep apnea for years without knowing it. And when it's left untreated, it can contribute to heart disease, diabetes, and other lung health risks. In today's episode, we have a very special guest who's an expert on sleep apnea. I'm very happy to welcome Dr. Mike Murphy from Inspire Sleep. Thank you so much for joining us today. Tell us more about yourself and your background.
Thanks so much for having me on. It's really a kind of a pleasure and an honor to be on your podcast today. I'm looking forward to a good session. So a little bit about my background. So I was raised in the San Francisco Bay Area, and I ultimately went to med school in St. Louis at St. Louis University, and went to Seattle, the University of Washington, where I did my otolaryngology head and neck surgery residency. And people, that's a long word with a big mouthful of terms in it. But basically, in the United States here, people typically refer that as ear, nose, and throat doctors, or ear, nose, and throat surgery. So, I tell patients we kind of do all surgery from the collarbone up, but we don't do the eye surgery or brain surgery, but we do ear surgery and sinus surgery. And for those of you with kids, we're the doctors that put in the ear tubes or take out the tonsils, and also deal with head and neck cancer. So there's a wide range of things we do. And I was very fortunate. I finished my training in 2002, and I was able to come home to where I grew up in the San Francisco Bay Area and kind of join my hometown ear, nose, and throat practice. And I've been there since 2002. I have the same two partners I had when we started, and we were in private practice for years, just the three of us. And I, over the time, just became so increasingly convinced of the importance of sleep that although I've been doing procedures for snoring and sleep apnea for years, I decided to become board certified in sleep medicine. And I did that in 2009. So I'm board certified in both. And so I think I tell people all the time, it doesn't make me better. It just makes me a little different. And I think when it comes to snoring and sleep apnea, it gives me a pretty broad perspective on how to approach patients with these conditions. So and then the other thing just about my background is my partners and I decided to partner up with Stanford Medicine in 2016. So we are now part of the larger Stanford Medicine network here in the Bay Area, and same practice, same location, same partners, just that larger affiliation with Stanford Medicine. And that's been really fantastic to be part of Stanford Medicine and have those resources involved. So that's kind of a Reader's Digest version of my background. And I really love what I do. And, I'm really appreciate you having me on the podcast. I really want to spread the message about the importance of sleep apnea. And right now I see patients in my office and I feel like I help them out. And right now it's one at a time. So thanks for having me on the podcast, because I really want to get the larger message out.
Thank you so much. And I'm thinking that we can start with that you can explain to us what sleep apnea is and what are the symptoms to be aware of, because there is not much awareness about this.
Yeah, that'd be great. Maybe what we'll do is let's start by putting snoring and sleep apnea into the larger context of sleep medicine in general. So yes. There's something called the International Classification of Sleep Disorders. And I'm sure you know all about that. Many of your listeners may know too, but for those you don't, all sleep disorders are categorized into one of 6 categories according to this classification. So for instance, there's insomnia, which is your area of expertise. There's something called the central disorders of hypersomnolence. And an example of that would be narcolepsy. There's circadian rhythm sleep disorders. Those are people that their body clocks off. So a lot of times that might be jet lag and travelers, or people who have shift work disorder and their shifts are always changing. There's a category called parasomnias, and those are the things where people have odd behaviors at night, like sleepwalking or other things of that nature. And then there are the, there's the sleep-related breathing disorders, and that's the category that snoring and sleep apnea fit under, called sleep-related breathing disorders. And, it's interesting that those are the 2 dominant category disorders in that category, but there's also central sleep apnea fits into the sleep-related breathing disorders. And I think we're going to touch on that a little bit later too. But By far, snoring and sleep apnea are the main ones in that category. And then the other category is something called sleep-related movement disorders. Those are people who may have restless legs during the day, and they have something called periodic limb movement disorder at night, where they have a lot of leg movements and body movements at night. So, but snoring and sleep apnea fit under the larger category of sleep-related breathing disorders. So that's the big picture. Now, what I tell my patients all the time is that when we're sleeping, our airway is just a spectrum in terms of airflow. So on one end of the spectrum is nice streamlined airflow, and the symptoms, no symptom, it's quiet breathing. Then at some point that streamlined airflow becomes turbulent and people begin to snore. And then further down the spectrum, that turbulent airflow actually becomes blocked or obstructed. And that's where people get into sleep apnea. And so really it's just a spectrum. And even with snoring, people will go from very light snoring, and we'll talk about the numbers in a little bit, to people who snore very loudly, and they snore habitually on a nightly basis. And, in terms of symptoms, as you snore louder and louder, obviously you're getting closer and closer to getting, falling off the fence and falling over into the area of sleep apnea. And then sleep apnea itself is a spectrum from mild to severe. So really our airway at night when we're sleeping is just one big, long, giant spectrum going from quiet breathing to very severe sleep apnea. And so that's the probably most important concept to understand right off the bat. And so when we talk about, well, how do you know if you're snoring or you have sleep apnea? In a minute, I'll talk about some testing we do and how we interpret that formally. But it really just starts with symptoms. So, if you're someone who snores on a nightly basis, the things that make you even more concerned that you may have sleep apnea, especially when we think about partners around you, is, studies show that if in addition to snoring, your partner actually becomes worried about your breathing, and they maybe witnessing some of these what we call apnea episodes, where there's a temporary blockage of the flow of air. That doesn't necessarily mean you have sleep apnea, but that's very predictive and concerning, and certainly merits looking into it more closely for sure. And then as far as the severity of snoring, it's not only just the frequency, it's also the severity. And typically we actually just measure that by how loud it is in decibels. So, if someone in your family says they can hear you snoring from outside the room with the door closed, that's probably not good. So those are just some things in terms of just basic symptoms, in terms of the actual airway at night that we think about. And then in addition to that, there are some symptoms the following day that also might give you some idea that there's something going on that's more serious than just snoring. And that would be, if you're waking up with morning headaches. Again, that doesn't mean you have sleep apnea, but as we'll talk about in a little bit, if your oxygen levels are actually dropping down at night, we call that hypoxia because your airway is blocking off temporarily. Some people, as a consequence, will have headaches when they wake up in the morning. So that's another sign to be wary of. And then finally, just, the effects on your daily functioning. If you're not getting good quality of sleep and you're having sleep apnea at night, your sleep's being interrupted, daytime sleepiness and trouble with memory and focus, those are all some of the symptoms that we, really ask about first. And a lot of it is when I see patients in the office, when I talk to them, and a lot of times their spouse may be with them in the visit, we have a pretty good idea, even before we start launching into formal testing, about whether or not someone may be at risk for having sleep apnea.
Yeah. This is so interesting. And I know that in Norway, 1 out of 5 people have sleep apnea, and that only 20% are getting diagnosed and treatment for it. And how is this situation in the US?
Yeah, it's these conditions are incredibly common. So snoring is a little bit hard because it depends on really how you define snoring. But the general consensus in the United States is, if you just call it habitual snoring, meaning people that snore on almost a nightly basis, incredibly, that winds up being about 40% of men in the United States. I'm talking primarily just about adults now, not kids or elderly people. And that, winds up being about 40% of US men. That's 50 million men. And it's about 20% of women. So that winds up to about 25 million women. So there's about 75 million people in the United States who are snoring on almost a nightly basis. And one thing we have to keep in mind, again, is that it is a spectrum. So snoring can actually be a sign of sleep apnea in and of itself. But it really doesn't matter. If you're snoring, you're still at risk. So that's a lot of people. Now, we'll talk about how we actually formally define sleep apnea in a minute. I'll go into that next. But if you actually have people that are diagnosed with sleep apnea on the basis of an apnea-hypopnea index, then those numbers wind up being about 35% of US adult men, 30 million men, and about 18% of women. So that's about 16 million women. So not only are there millions and millions of people who are snoring, but there's also tens of millions of men and women in the United States who have obstructive sleep apnea. So the numbers are really high. And they actually did a study in 2015 where they did some large population surveys where they reached out to people and they asked them about various conditions. And so when they actually screened people and asked, there was about 80% of people in this particular study that had clinically significant sleep apnea when they were asked about it in these surveys that hadn't really had a formal diagnosis yet. So that kind of just dovetails with what you're saying in Norway, that there's a lot of people who are snoring on a nightly basis and likely have sleep apnea on a nightly basis that aren't currently diagnosed. So it's a problem. And one of the reasons why I really appreciate you having me on the podcast is a lot of it is just spreading awareness. There's this kind of conception that snoring in and of itself is just a quality of life issue and it's otherwise kind of harmless. And it's not at all. Studies have shown that even if you just snore and don't have sleep apnea, you're at increased risk for hypertension. And you also have a lot of the daytime symptoms of poor quality sleep, even if you're just snoring, let alone, if you have sleep apnea.
So what are the consequences if you're not getting any treatment for your sleep apnea?
Yeah, let's talk about that. What I'm going to do just real quickly, if you don't mind, is I want to circle back and just talk a little bit about how we formally diagnose it. So we kind of put everything in perspective, if that's okay with you.
Very good.
We can talk about the symptoms. And then after we talk about the symptoms of just what people are observing and some of the symptoms you may be having during the day, there are a couple of questionnaires that are well validated that can be used to help people get an additional idea about whether or not they're snoring or have sleep apnea. So the main one that I would, and just let your listeners know about is something called the STOP, STOP-BANG, BANG questionnaire. And that's a questionnaire that's been used for a long time and it's well accepted. And it asks you just some basic questions about whether you snore at night, if you're tired. It has some questions about your neck circumference, and you just work your way through. If you go on the internet, you'll see a copy of that. And that can give you, in addition to the symptoms that you may know about, what your spouse may be commenting, that can give you even better idea about whether or not you're snoring or have sleep apnea. And then in terms of the daytime consequences of, for instance, sleepiness, there's something called the Epworth, EPWRTH, Epworth Sleepiness Scale, which I'm sure you're well familiar in your practice. It could be for insomnia as well as sleep apnea. It's just not for sleep apnea, but that also gives you some idea about how sleepy you may be the following day as a consequence. But ultimately, to be diagnosed with sleep apnea, and this is a really important point, if you're listening out there to the podcast and you're concerned you may have sleep apnea, ultimately that's going to require being, evaluated and seeing a provider for that, so they can see you and examine you and get you evaluated in the system. And here in the United States, ultimately people need to have what's called a polysomnogram or a sleep study to be diagnosed with sleep apnea. And for years, those studies were always done in a lab. You'd go sleep in a room and they'd hook you up to a bunch of electrodes and monitors and monitor you in a lab. And we're still doing that in the United States, but more often that's for people that we really are worried about have a lot of other significant potential health conditions like heart arrhythmias and things. And increasingly, people are just getting a sleep study at home where they sleep in their own bed. We do one of those through my practice. And at the end of the day, in terms of sleep apnea, there's really two events that we really measure and we total up. One is called an apnea. And basically an apnea is defined as a 90% blockage or more of airflow in your airway. We can talk about where a little bit later, for at least 10 seconds. And if you have one of those episodes, we call that an apnea. And then the other episode is called a hypopnea. And that's a 30 to 90%. What I just tell my patients in the office, it's a partial obstruction for at least 10 seconds or more. So it's not as severe as an apnea event, but a hypopnea event is still an event nonetheless. So at the end of the day, what all these sleep studies do, whether you're in bed at home or whether you're in a lab, is they're totaling up these events that are occurring at night and they just divide it by the amount of time you're asleep. And they come up with something called the apnea-hypopnea index. That's basically events per hour. And that's the basic measure we use to, number one, diagnose sleep apnea. If you have over 5 events per hour, that's a diagnosis of sleep apnea. That's the numbers I referred to earlier. And then if the events are between 5 and, between 5 and 15, that's mild sleep apnea. 15 to 30 events is moderate sleep apnea, and anything over 30 events per hour is severe sleep apnea, because if you think about it, it's per hour. So you're having an event every other minute or more. So just wanted to take a minute to explain to everybody as we launch into some of the consequences of sleep apnea, the kind of the formal way that it gets diagnosed.
Thank you so much.
Yeah.
So, but the consequences if you're not getting treatment.
Yeah, let's talk about that. So so basically what happens is, I like to think in terms of pathways. So when someone has sleep apnea, there's 2 major pathways that lead to the problem. And the 2 major pathways are, number one, you can think of it as kind of fork in the road. So the first pathway is what we call respiratory arousals. And basically what that is, as we're sleeping, there's different stages of sleep. And if you have really significant or severe snoring, and even more if you're having these hypopnea or apnea events, what happens is when these events occur, you ascend to a lighter stage of sleep, to a different stage of sleep. And our body has an autonomic or automatic nervous system, and it's broken into 2 different systems. There's the sympathetic, I call that the gas pedal of our body, because it's kind of the fight or flight response. And there's the parasympathetic, I call it the brakes. That's where our body kind of slows down and repairs itself. So it turns out that in the deep stages of sleep, or restful stages of sleep, that's where the parasympathetic nervous system kind of takes over. And it's when our blood pressure goes down and our heart rate goes down, our metabolism goes down, so our body's not as revved up. And so and it's also the stage where our brain kind of clears out the products of the day's events. And so unfortunately, it's during the stages 3 and 4 of non-REM sleep, which is kind of the restful, deep stages of sleep. That's where the parasympathetic nervous system takes over. And unfortunately, when you're having these snoring and snoring and apnea events, what happens is the exact opposite happens. Our body goes into fight or flight mode. And so that activation of that sympathetic nervous system kicks in, and the blood pressure and heart rate go up. And so night in, night out, over a long period of time, that's why it can lead to, cardiovascular conditions such as hypertension. And so in terms of our brain health, like I alluded to, it's during those restful stages of sleep where the parasympathetic nervous system, where our brain clears out the activity of the day. And in terms of cognitive impairment and dementia development and other things with sleep apnea, if you're not spending enough time in these restful stages of sleep, then some of these harmful byproducts can build up over time. And that can lead to, some of the cognitive effects as well of sleep apnea. So the first pathway are these respiratory arousals and the activation of the sympathetic nervous system. And then the second pathway, and this isn't so much with snoring, this is more with the actual hypopnea and apnea events, is actually intermittent hypoxia. So as our airways blocking off, our oxygen levels are going down. And that just creates a cascade of inflammation and other problems in our body. And ultimately, that can lead to damage of the inside of our blood vessels. We call that the endothelium, and plaques can form. And then platelets, which are part of our body's clotting system, get activated. And ultimately, that can lead to formation of clots and the cardiovascular consequences of all that. So there really is these 2 main pathways, the fragmented sleep and then the hypoxia. And then it doesn't matter if it's your cardiovascular system or your neurologic system or the metabolic system. These things kick in, and then these harmful effects begin to kick in. From a metabolic standpoint, that's probably the last one we might want to touch base on, is we know that when you're not spending enough time, again, in that restful stage of sleep, those deep stages of sleep, it actually leads to insulin resistance in our body. So insulin is what takes the blood sugar in our blood and brings it into the cells of our body out of our bloodstream. And so when insulin resistance occurs, there's more insulin circulating in our bloodstream. And then, so that's the slow wave sleep kind of pathway of that. And then the second one is, again, with the hypoxia and the damage to the inside of the blood vessels and other tissues, the beta cells in the pancreas that make the insulin become damaged as well. So not only are you not making enough insulin, the insulin you do have isn't working as well. And that's one of the reasons why snoring and sleep apnea, if they're not treated over time, are correlated with prediabetes and ultimately the development of type 2 diabetes as well. So that's just one example from a metabolic standpoint. And there's many more, but it's important to understand that those are probably the two main pathways that cause damage and the consequences of this if it's not treated.
Thank you so much. You know, this tells a lot about why it's so important to spread the knowledge about sleep apnea, so that people can get it checked up if they have
and
any
it's
symptoms.
really it's really interesting. If you look at the data in the United States, about 50% of patients that have coronary artery disease in the United States will have sleep apnea associated with it.
Yeah.
And the numbers are very similar. So about 50% of patients in the United States who have hypertension have sleep apnea if you check them. Yeah. So you think about how sleep apnea leads to cardiovascular disease, but you can also think about it the opposite way. And the way to think about that is if you're someone who has hypertension, you should be checked to make sure that you don't have sleep apnea. Or if you're someone with coronary artery disease, same thing, same principle. If you're someone who has pre-diabetes or diabetes, then you need to make sure you don't have sleep apnea. And especially if you have hypertension or diabetes or prediabetes and you have the very symptoms we started out our conversation talking about. You're snoring very loudly. People can hear you snoring from outside the room. Your partner's shaking you at night because they're worried about if you're breathing correctly. So these things, from a clinical standpoint can get complicated, but just from a practical standpoint, when you start to realize these things are associated, then it's much easier to say, I may have a problem here and I need to get it looked into.
Very good. Can you also explain the difference between obstructive sleep apnea and central sleep apnea? Because I know there are many people, they are not aware about these two.
Yeah. Central sleep apnea is much less common. And I have to give all the listeners here a little bit of a caveat. As a surgeon who treats patients with snoring and sleep apnea, I'm not an expert at that, and I have sleep medicine colleagues who manage a lot of patients with central sleep apnea, but there's a fundamental difference that's important to understand. And so the way to think about it is an apnea just means that you're not breathing for 10 seconds or more. And then it breaks into two different pathways again. Either you're not breathing for 10 seconds or more and you're trying to breathe, that's obstructive sleep apnea, or you're not breathing for 10 seconds or more and you're not even making an effort to breathe. And that's central sleep apnea. And that's something that is more, like I said, centrally, it's more related to the brainstem and our drive to breathe in the first place. And it can be the case, and we see it often, that if someone has real severe obstructive sleep apnea, sometimes they'll have secondary central events. And if you treat the obstructive sleep apnea with CPAP or other things we'll talk about, the central events will go away. Primary central sleep apnea is a completely different thing altogether. That's where people have way more central events, apnea events, than they do obstructive events. And that's more indicative. We see that more often people that may have, underlying significant cardiovascular disease, or, sometimes what we need to do is do an MRI to make sure there's not something going on at the level of their brainstem. That's where our respiratory drive comes from. So it's a different workup altogether. And it's also a different treatment. There's something called adaptoservoventilation, which is, it's still a machine that helps you breathe, but it's different from a CPAP machine. And again, the key difference is with central sleep apnea, you need some additional help because you're not even making an effort to breathe, as opposed to, needing help to keep your airway open. Mm-hmm. So it's even more important that if people have a potential central sleep apnea condition, it's really essential that those people be seen and evaluated by a sleep specialist, who has expertise in evaluating and working up and treating those patients.
Yeah. And I know that many people are struggling with using the CPAP, and they might not be aware that there are other options, if they have obstructive sleep apnea. So can you tell me about Inspire Sleep, how it works, and why it's so important to be aware of this for people who struggle with using CPAP?
Yeah, that's a great question. What I like to kind of explain to my patients in the office, usually what they'll happen is they'll have their home sleep study and they'll come back and see me, and I'll be diagnosing them with sleep apnea. And, basically what I tell them is that in terms of treatment, I call it kind of the fork in the road approach. So, everybody's kind of walking down the road together in terms of treatment. And the first fork in the road is kind of surgery or no surgery. That's the first fork we get to. And there's different levels that can be involved with your sleep apnea. And that's another important concept to understand, is that if you kind of follow the flow of air from the opening of your nose down to your vocal cords, which is the opening to your windpipe, there's different levels where your airway might be blocking off. And it's really important to understand where the problem is, because you may, for instance, have more than one level. And so when it comes to the nose, and this really relates to your question about CPAP, we're designed to breathe through our nose. That's how we were designed to breathe. And so if we don't breathe through our nose during the day or at night, we're breathing through our mouth, and that leads to a whole kind of cascade of problems. But when it comes to your nose, it's really just a math problem with two variables in terms of how your nose works, and that's day and night. So you have your structure of your nose, that's one side of the equation, and the other side of the equation is the lining of your nose. And it's really important, if you're not breathing through your nose, to figure out what the problem is. Because the first thing you're going to do if you don't breathe through your nose is you're going to be breathing through your mouth and snoring at night. And in addition to that, if you're trying to use CPAP, especially if you're trying to use CPAP through your nose with nasal pillows or a nasal mask, you're trying to push air under pressure through your nose, and there's some obstruction to that. So it's really important. The most common thing that people will have going on with their nose would just be allergies, at least here in the United States. A lot of people have allergies to the environment, to pollen and other things, and that causes a lot of congestion in their nose. And that can be treated with saline irrigations, and there's some over-the-counter medications such as nasal steroid sprays you can use for short periods of time. You want to be under the care of a physician if you use those nasal steroid sprays for long periods of time. And ultimately, you can be evaluated by an allergist or your primary care doctor. Lots of people in the United States might take an over-the-counter medication like a Claritin or a Zyrtec, an antihistamine for their allergies. That would be one side of the equation. The other thing, some people might be prone to sinus infections or other things. And so that's the lining side of the equation. From a structural standpoint, people will usually know if they have a structural problem in their nose. And the reason why you'll know that is you won't be able to breathe well out of one side of your nose and compared to the other. And the structure of your nose never changes. So these are the people who say, boy, I just don't breathe well through the left side of my nose. And I never do. I don't breathe well through my nose during the day or night. And a lot of times those patients will come to see me, and the septum separates our nose into two cavities in the center of our nose. And people may have a deviated septum from a sports injury or some other thing. Or for some people, I tell them your septum just drifts over time. There's no obvious reason why it's more to one side or the other. But again, back to treatment. So when we talk about treatment, if you need surgery, the surgery depends on the level. So if you've got a nasal problem, we'll do a nasal surgery, and the surgery depends on the problem. The next level down would be the tonsils or the palate. And some people, have big tonsils, and those big tonsils really fall back and block the airway. The tonsils are the tissue in the back of your mouth next to your tongue back there. They're part of your immune system, and they get smaller over time. But in some people, even adults, they'll still have real large tonsils. And those tonsils will, create problems with the airway. They can be removed. It's an outpatient surgery that we do if we need to. Tonsil tissue is a big issue with the kids, by the way. Most of the time, if kids have sleep apnea, that's the primary thing we talk about. If you have a problem with your tongue blocking your airway, that's what you alluded to with the Inspire device. And that's really the primary level where the Inspire works. And what it does is the hypoglossal nerve is a nerve that moves our tongue. And we go to the operating room and we make an incision under the front of the mandible or the jaw there and identify the nerve that moves the tongue, the hypoglossal nerve. And we find the branches that move the tongue forward. There's branches that move the tongue back. We don't want those. That would block your airway. So we find the branches that move the tongue forward. We use a microscope and do nerve stimulation. And we put an electrode around those branches of the nerve. And then we go down into the chest. It's on the right side instead of the left side. So think of it kind of like a pacemaker approach, but on the opposite side, on the right side. And what we do is we create a little pocket and put in what's called the pulse generator. I tell my patients it's kind of the brains and battery to the device. And through that incision in the chest, the same incision, I go between the second and third ribs, and there's breathing muscles. We call them the intercostal muscles. And we slip in a little respiratory sensor between those breathing muscles. And we hook all those things up. And the way that the device works is when you go to take a breath at night, the respiratory sensor in between your ribs sends a message to the pulse generator, which sends a message to the electrodes around the hypoglossal nerve, and the tongue comes forward to open up the airway at night. So as people are breathing, their tongue's coming forward to open up their airway. And it's controlled with a handheld device. It almost looks like a TV remote control. And so, for the appropriate patients here in the United States, increasingly, that's a really good option. And the results are good when the patients are appropriately selected. And one of the things you alluded to is there are certain criteria in the United States to be approved for this hypoglossal nerve stimulator device. And the main ones are that, number one, the sleep apnea has to be a certain severity. We alluded to that. So the apnea-hypopnea index has to be between 15 and 65. So you can't have mild sleep apnea or super severe sleep apnea. You have to be somewhere in the middle. And then patients need to be intolerant of CPAP. And that's what you had kind of mentioned as well. Patients who just aren't able to tolerate their CPAP. And I started off this discussion by talking about the importance of understanding what's going on with your nose, because it's not uncommon that patients will come to see me to inquire about the Inspire device because they haven't been able to tolerate the CPAP. And it turns out when I actually start to see them and examine them and evaluate them, that they've got a nasal issue that can be pretty easily addressed or purely easily managed, whether it's maybe a short outpatient surgery for something, or it might be as simple as getting their allergies or their nasal medical conditions under control. And then these patients are able to better tolerate CPAP treatment. So the first fork in the road is surgery. And then back to our discussion, the second fork in the road in terms of treatment for sleep apnea is the non-surgical path. And that forks, again, there's two main options for people. One is positive airway pressure, CPAP. The other is an oral appliance. And that's an interesting thing. Here in the United States, I think that's really underutilized. And so what an oral appliance is you, and here in the United States, again, patients are referred to a dentist that's specially trained, and they're experts in occlusion. And what they do is they make an appliance. They take impressions of the patient's teeth, and they make an appliance that they wear at night. And the way the appliance works is there's an upper and a lower piece. The upper piece goes into position because your upper face doesn't move at night. And then the lower piece attaches to the upper piece. And because it's attached, it can be advanced forward. And I tell my patients that your tongue and your lower jaw are a unit. They go together. So as the appliance brings that lower jaw forward, your tongue's going to come with it to open up the airway. And the goal with an oral appliance is to bring the jaw forward enough to open your airway, but not so far forward that it's stressing out your teeth and the joints in front of your ears. We call those the temporomandibular joints. And for people who primarily have a lot of obstruction at the level of their tongue and their jaw, that can be a really good option. And the American Academy of Sleep Medicine says actually that the oral appliance can be a good first line of treatment instead of CPAP for patients who have mild to moderate sleep apnea. So I think in the United States that's a treatment that's underutilized actually. So that's always something to keep in mind as well. And then CPAP again is the gold standard for a reason, because there's not a lot of medical complications or side effects of CPAP, assuming you can tolerate the treatment and assuming you can handle it. And for patients with real severe sleep apnea, especially if they have a lot of the cardiovascular and metabolic neurologic consequences we talked about, I usually recommend that we get them on treatment right off the bat with CPAP, just because I'll tell them that when you get up in the morning, you look at your machine and your machine's going to tell you if you've had any events. And the newer machines have software. You have an app on your phone where you can see how you did. They'll give you a smiley face or not from the prior night's sleep. So it's really important for people who have real severe sleep apnea to get started on CPAP and really work to make sure that that's working for you. And not necessarily for the rest of your life, but for that period of time that allows you to begin, getting a good night's sleep and reversing some of these damaging consequences that occur if your sleep apnea is not being treated. So, and again, that gets back to sometimes just making sure that we're identifying what the problem is with tolerating the CPAP and working through those issues to kind of figure out what it is and try to solve that.
Yes, and I think this is so important because there are many people who doesn't tolerate CPAP, and it's so important that they know that there are alternatives. And for instance, in Norway, there are many dentists who are certified in this area and where you can get this oral appliance. And I think this is probably more normal in Norway than in the US. But always they get CPAP first, so and there are many who doesn't tolerate it.
I agree with that. And again, I think that with CPAP, one of the things that's real important, and one of the reasons why I talked about the fact that there's different levels in our airway that can be involved. It could be your nose, it could be your palate or tonsils, it could be your tongue. One of the things we haven't talked about is weight, and weight's one of the things where there's a very, very clear correlation between sleep apnea and weight. And here in the United States, obesity and weight gain is really an epidemic almost. So that in 2020, 42% of US adults were obese. And in 2015, that number was 33. So it went from 33% to 42% just in the course of 5 years. One of the things with sleep apnea is that when you're having these metabolic consequences of the sleep apnea that's not treated, the body doesn't process calories efficiently. One of the things that leads to is weight gain. And then the weight gain feeds into the sleep apnea. And I tell my patients, it's kind of a snowball rolling downhill. So, weight is one of those things where the bad news is there's a clear correlation with sleep apnea. The good news is that's something that, can be addressed. So when patients put on weight, the first thing we think about in terms of the mechanisms for sleep apnea is they put on weight in their neck. And so that stop bang questionnaire, for instance, that's screening for sleep apnea, one of the things that's included is a question about your collar size. So we know if you're a man or a woman and your collar size around your neck is over a certain number, around 16 or 17, that puts you increased risk for sleep apnea because you're putting on weight in your neck. But there's some really amazing studies where they found out that patients also put weight into their tongue. So they've done studies where they do an MRI scan and they measure the size of someone's tongue, and then the patient loses weight and they repeat the MRI scan and the tongue's smaller. So we know that weight's deposited in the tongue as well. So, a lot of times, the sleep apnea, again, the CPAP can be something where people are having trouble tolerating it. But if we can get them to, pursue some weight loss and other things, then we talk about oral appliances and other particular, other solutions. And the most important thing is what you're trying to do is you're trying to identify the cause, right? You want to identify the cause of the problem and address the cause of the problem, as opposed to just treating it over time without addressing the underlying cause. So that's where if it's a nasal problem or big tonsils, or maybe there's a weight component you're going to work on, the goal is to get through those issues, identify the cause and treat the cause so that you're not feeling like you're, someone's giving you a prescription for a machine for the rest of your life.
And before we end today, I also want to spread some awareness about the more subtle symptoms of sleep apnea, especially for women, because I know it's not necessarily that snoring is occurring, because I have had clients who have severe sleep apnea and they are not snoring. So what symptoms should they look after if they are not snoring and they might have sleep apnea?
Yeah, that's a good point. There's a couple symptoms that I usually think of, and in the idea of the spectrum going from quiet breathing to snoring to obstructed breathing, it works in general and it covers most circumstances. But as you just talked about, it doesn't cover all of them. So one of the main symptoms that even if people don't snore, if they say that they wake up gasping, that's one of the things where they'll wake up and on occasion they'll wake up gasping or feeling like they've just been in a sound sleep and they wake up and they're gasping for air. That would be one symptom. Another symptom would be, waking up with a racing heart. So if you're waking up at night with a racing heart, that could be a sign that fight or flight pathway that we talked about with the sympathetic nervous system is kicked in and it's causing your heart rate and your blood pressure to go up. So that would be one. The third one would be, there's lots of reasons why as we get older, we'll have to get up and go to the bathroom a lot and more than we would expect at night. But there is actually a mechanism through those respiratory arousals where it can actually lead to episodes of having to go to the bathroom at night. So having to go to the bathroom at night a lot, waking up with a racing heart, usually, especially if someone's not particularly heavy and they're relatively thin, if they're having episodes where they're waking up gasping or they're feeling their airway block off, I get real suspicious in those people that they may have some degree of obstruction at the level of their tongue. And that really relates to jaw structure. And that's just kind of how we're made. Because if you think about your lower jaw, that's the bony box your tongue has to fit into. So For instance, a really interesting story. My wife went to the University of Washington, and as an undergraduate, one of her good friends was thin and in great shape and very athletic, and she had severe obstructive sleep apnea. And it had to do, and she wasn't a super loud snorer. She was super tired during the day, had a lot of the symptoms we talked about. And it had to do with her jaw structure. She had a real kind of narrow jaw, and it was forcing her tongue to be more posteriorly positioned. And she identified that and got that addressed, and it made a big difference for her. And again, she was one of the people that didn't fit into your classic picture of someone with sleep apnea. So those would be a couple symptoms right off the bat, that I would think about. And again would be the morning headaches, right? We talked about that as well.
Yes, this is so important and so interesting. And, it's just, contact your doctor and get a home sleep test to check if you have sleep apnea, if you have some of these symptoms.
Yeah, I think that really is the take-home message. There's a lot of things you can do, over the counter products and other things, maybe with nasal symptoms, and a lot of things you can do to kind of investigate yourself. And hopefully this podcast has helped, because one of my pet peeves is people spending a lot of time at the internet without having a lot of direction, and we don't want people to waste their time. But being careful about those symptoms, about snoring loudly at night, and maybe people being concerned about your breathing, a stop bang questionnaire to give you a basic idea about what's going on. But at the end of the day, if there's any question about whether or not you have sleep apnea, then it's a matter of finding a provider and starting the process of seeing if that's the case. And if in fact you do wind up being diagnosed with sleep apnea, working hard to try to figure out what the underlying cause is and trying to address that underlying cause, whatever it might be.
And Dr. Mike, where can people find you?
So the best way to reach me, and I'm give all the listeners out there a caveat. Like I alluded to, I'm just getting started with this. I've been busy clinician for years and reaching out now to trying to get the message out to the larger public. So I'm at Sleep Checkup MD. So at Sleep Checkup MD. You can find me on Twitter and Instagram. And then there's a website, www.sleepcheckupmd.com. And so I'm just getting started, but those are ways where you can reach out to me. And I'm increasingly being active in terms of, posting on social media about articles I may read that I think are relevant for all of you out there, and, working hard to get the message out.
Thank you so much for being with us today. It's been so interesting, and everyone, I hope you have enjoyed this podcast today, and we are looking forward to see you soon. Thank you so much.
It's my pleasure. Thank you so much.